Hello everyone, welcome back to my channel. Today we will discuss about recurrent genital tuberculosis. Okay, all the pathogenesis of genital tuberculosis and the clinical overview, diagnosis and management. I will post a different video of genital tuberculosis, but here I am discussing about the recurrent genital tuberculosis. Okay, so what we'll learn here: the clinical overview, diagnosis and management. Then coming to the introduction, see, genital tuberculosis, it is a form of extrapulmonary tuberculosis affecting female reproductive organs. Most commonly, it involves fallopian tubes, endometrium and ovaries. Okay, so fallopian tubes, the innermost or the mucosal surface, it is most commonly involved, and endometrium as well as the ovaries. Okay, the least involved is the ovaries. In recurrent genital tuberculosis that occurs after prior treatment or incomplete eradication, let the genital tuberculosis has occurred and we have taken the treatment. Okay, then now there occurs another active infection of genital tuberculosis, and then we take the treatment, and previously let the treatment was incomplete or relapse has occurred once again, the case is defaulter. Okay, if already prior treatment has been taken or incomplete eradication of the genital tuberculosis, then this is called as the recurrent genital tuberculosis. Okay, then what are the risk factors for the recurrence? So why the recurrence is happening? Because of the incomplete or irregular anti-tubercular therapy. This is the most common cause, that we are incompliant to the anti-tubercular therapy, and also drug resistant mycobacterium tuberculosis due to the resistant by the mycobacterium tuberculosis, the drug resistance. Okay, then poor immunity or malnutrition. Okay, immunocompromised patients, they are more at risk for the recurrence of the genital tuberculosis, and the delayed diagnosis during the initial infection. If more time the initial infection or the primary infection or the last time the infection that was taken place, okay, the infection has occurred and now the diagnosis is that previous disease was being diagnosed late, or the delayed diagnosis during the initial infection, that also leads to that is also a risk factor for the recurrence. Okay, then what are the clinical features? See, the most common presentation is the infertility. Okay, the infertility, it is the most common presentation. Also that may lead to chronic pelvic pain, may lead to dysmenorrhea, and also menstrual irregularities like oligomenorrhea or amenorrhea, and the pelvic adhesions due to the genital tubercular infections, that there occurs pelvic adhesions and tubo-ovarian masses, and that may complicate the situation. Okay, so these are the clinical features as well as the complications of recurrent genital tuberculosis. Then how to diagnose the recurrent genital TB? How to diagnose? See, one confirmation is endometrial biopsy for histopathology. In histopathological examination, we can see directly the tubercular features of the endometrium. In the biopsy itself, we can see, and CBNAT or gene expert testing. In CBNAT, we can see the presence of the disease as well as we can see the rifampicin resistance also. Okay, so here CBNAT also helps in knowing the rifampicin resistance. And third one is the PCR for tuberculosis, and laparoscopy or hysteroscopic findings. Directly we can put the scope and see, but the thing is, if we directly put the scope, then there are chances of dissemination. Okay, and also drug sensitivity testing, we can directly see the tubercular agents. Then coming to, this is the most important part, the treatment. So what is the treatment regimen? See, this is the retreatment regimen. That means we are already, the patient has received the antitubercular therapy for the genital tuberculosis, and then the infection has reoccurred, and then we are giving another regimen or another treatment we are giving. So this is different. This is the duration is for 8 months. Previously for the primary treatment, okay, the primary treatment, what are we giving? We are giving for 6 months. Okay, 2 plus 4 months we are giving HRZES plus HRZE. Okay, then but it's we are giving HRZE plus HRE. Okay, we were giving what for 6 months, but here in the retreatment regimen the difference is we are giving for 8 months. Okay, see this one, you remember, we are giving for 8 months and we are giving 3 months of intensive phase plus 5 months of continuation phase. HRZE plus HRE, that is 3 plus 5, total is 8. Okay, so this is the thing we have to remember. That regimen is very simple. We have to remember total duration of 8 months. We will give 3 months of HRZD plus 5 months of HRE. So total of 8 months. So this is the treatment regimen for the recurrent genital tuberculosis. Okay, then if at all we need surgical management, that is, what are the indications for surgical management? If for severe pelvic adhesions, okay, that may lead to infertility, then we have to do adhesiolysis. If tubovarian abscess is present, severe infection is present, then we have to drain the tubovarian abscess. And if severe tubal damage is present, we have to do salpingectomy, in hydrosalpinx also. Okay, and surgery, but it is mainly reserved for complications. Okay, so these are the complications: severe pelvic adhesions, tubovarian abscess, and in severe tubal damage. We can do adhesiolysis, drainage of the tubovarian abscess, and salpingectomy. Okay, so these are the, if at all surgery is indicated, then we can do all these things for the surgical management. Okay, then fertility management after treatment, we have to assess the tubal patency after completion of the therapy. Okay, so we have to see that if the tube is patent or not. Then spontaneous conception is also possible. In mild disease, spontaneous conception is possible, and we have to do IVF if required, and early treatment, it improves the reproductive outcomes. Okay, so we have to start immediate management after confirmation of the diagnosis. So what are the things you have to remember? The key takeaways are: fallopian tubes are the most commonly affected organ. Okay, most commonly affected organ is the fallopian tube. Infertility, it is the most common clinical presentation. Early diagnosis and adequate ETT are crucial, and drug sensitivity testing, it is essential in recurrent disease. Okay, so drug sensitivity, we have to, how do we know the rifampicin resistance? I have told you now, by Sibinat we know the rifampicin resistance. Okay, thank you.